आवाज नहीं आ रही थी. हाँ. Hi guys, good evening and welcome to this deliberation in Obs and Gynae, and some glitches here and there because this is a new system. We are all getting used to this, so I hope we are pardoned for this slight glitch in the beginning. So yes, welcome again, and I can see a few of you are there already, and we'll make good use of the time we have. So today we are going to discuss about preeclampsia and eclampsia, major medical disorder which presents in pregnancy. We must understand that when a patient has a medical disorder in pregnancy, the most common is hypertension. Of course, you have to keep anemia out of this equation because anemia is so common, then that becomes the most common medical disorder. So the major medical disorder which presents to us, almost around 7 to 8% of women who are pregnant may have hypertension pregnancy. Now, hypertension pregnancy, if we see the classification here in front of you in the first screen, must understand that it can be gestational hypertension or chronic hypertension. Now, before we go into detail, extremely easy to understand. This is a small girl, she is 10 years old, and when she is 10 years, she already has hypertension, let's say essential hypertension. When she becomes pregnant later in life, maybe around 30 years of life, at that time when she has a pregnancy, her blood pressure is already high in the first few weeks of pregnancy. So that is chronic hypertension pregnancy. Or she could get pregnant for the first time when she, let's say, a primary graduate at 25 years, she's never been pregnant before. Now she's got pregnant at 25 years, and at 25 years of pregnancy, she was never having hypertension. Now at 25 years, the first time she gets blood pressure high after 20 weeks of gestation, that becomes gestational hypertension. Both can present in pregnancy, a chronic hypertension or a gestational hypertension. Now you guys think and tell me which one will have the worst prognosis, the hypertension which is present ever since she was 10 years of age, or the hypertension which is present now after 20 weeks of pregnancy, which is going to be the one which is going to make her have the worst prognosis. So yes, the pregnancy which is present, the hypertension which is present from a very long time, that chronic hypertension will present with a major problem in pregnancy. Although देखो भाई, इसमें do not get confused at all. Hypertension pregnancy can be gestational or chronic. Either way, the drug of choice is labetalol. That nothing changes. Drug of choice is labetalol. But yes, either way, you must understand when you're giving labetalol, the patient with chronic hypertension is going to behave worse because she's going to be having chronic problems like retinopathy, nephropathy, neuropathy because of the hypertension which is present for the last 20 odd years. So she'll do worse in pregnancy. So yes, pregnancy hypertension, it can be chronic hypertension like she has essential hypertension, pheochromocytoma or a renal artery stenosis. This is worse prognosis in pregnancy. All right guys, then the hypertension which is present for the first time in pregnancy, that is the gestational hypertension. Now this, all of you know, the blood pressure is more than 140/90 after 20 weeks for the first time in a previously normotensive woman. Yes, we are going to write less. I just wanted to just introduce this topic to you. We are in the mode of doing the INICET Sankalp. So yes, just introducing this topic once again to you. We'll pick up pace now. So chronic hypertension, gestational hypertension, BP more than 140/90. This obviously means chronic hypertension means BP 140/90. Yes, excuse me, more than 140/90 before 20 weeks. That's all. So what do you think could be the culprit? What do you think could be the culprit that a patient is getting hypertension in pregnancy? That's what we're going to discuss in the etiology. So first, the definitions: gestational hypertension more than 140/90 after 20 weeks. Some people say you must check it at least twice, because when she comes to the hospital, she looks at me and she says, oh God, male doctor. First thing she gets scared is, if there's a doctor who's looking at me and he's a male, so she may get a little bit of hypertension just seeing the white coat. That is not hypertension until unless you check it twice. So twice the blood pressure should be high, that is with a 6 hours gap. So that also is part of the definition. A lot of people say that. So preeclampsia is what? All of this plus proteinuria, that is more than 300 milligrams in 24-hour urine. Yes, in 24-hour urine, if it is more than 300, you know, the lady has to give urine in a box. You know, she must collect the urine for the whole 24 hours, bring it to me in the OPD, and in that urine you look for the total amount of protein, or that is also known as 0.3 grams, 0.3 grams in 24 hours, or 1 plus on dipstick. And what is very important, we can also say more than the urine protein ratio, more than 3, more than into 3 is the urine protein versus creatinine ratio. So if the urine protein is getting to be more, then the urine protein creatinine ratio increases more than 0.03. So it's generally 0.02 as the upper limit. And along with this, if she has generalized tonic-clonic convulsion, now that is what is known as eclampsia. So these are the definitions. And eclampsia, please remember, it is not just any convulsion, it is generalized tonic-clonic convulsion. If it is absence seizures and it is partial seizures, myoclonic seizures, all those don't constitute part of the eclampsia. Eclampsia is generalized tonic-clonic seizures. And when a patient has seizures, convulsions in pregnancy, I am talking about eclampsia. Hypertension in pregnancy, the drug of choice, yes, we are going to discuss drug of choice is Maxial. Oh, hello, we are not talking epilepsy in pregnancy. Do not get this very basic mistake. Epilepsy in pregnancy also can give convulsions, head injury or a intracerebral space occupying lesion, or they could be a metabolic problem or a cysticercosis. Epilepsy in pregnancy can come, drug of choice is lamotrigine, some other time, some other place. We are talking about eclampsia, which is hypertension and a convulsion. So do not get confused with epilepsy. Now, there's something else which you should understand, that a patient may have something called a delta hypertension. So what is the delta hypertension? That is, the BP stays low. BP is within normal limit. WNL I have written here. Blood pressure is normal, but it is low normal in the early pregnancy and it becomes high normal in the later half. Very simple. Blood pressure is 110 by 60, 110 by 60 throughout in the first trimester, 110 by 60 in the second trimester, third trimester it becomes 130 by 84. Now, why am I screaming? 130 by 84. Arey bhai, why are you shouting? 130 by 84 for a woman who is having 110 by 60 earlier is hypertension, because this is now higher than the baseline the body is used to. That is known as delta hypertension, which presents later half of the pregnancy, let's say later end of the pregnancy, let's say around 35-36 weeks. And that can even cause a woman to have, yes, proteinuria, HELLP syndrome, eclampsia again. So delta hypertension is not new, but yes, do not miss out on that. So that's about the classification of hypertensive disorder in pregnancy. And now, when there is eclampsia, what happens next? So this is what we have to know. When there is eclampsia, next she's going to have a lot of problems. Look, let's go back to the previous slide. When a woman is convulsing, you know, that generalized tonic-clonic convulsion, the whole body goes into like big tone like that. You know, the whole body's tone is high. The back will arc. The back will arc like a bow. We call it opisthostosis, isn't it? The whole body arcs with a big increase in tone, and then clonic action, clone. The whole body is convulsing. Now, please understand, when the whole body is convulsing, is she breathing at that time? She is not breathing. You know, nobody can breathe while she is convulsing. So that moment for that convulsion, which is 20 seconds, 30 seconds, she is not breathing. So she is getting a hypoxic damage. Who else is getting hypoxic? The fetus. Mother may withstand 2 or 3 convulsions, but the baby with 3-4 convulsions may have a permanent hypoxic damage. With convulsion for, let's say, 10-15 convulsions, the baby will be dead, and the mother will have permanent lifelong hypoxic brain damage, if at all she survives, that is. So please understand, convulsion in eclampsia is the worst case scenario. Yes, whatever you're doing, now get into the groove for this chapter. This is a very, very important chapter, and we must understand the funda in the first screen. I'm not jumping into the etiology and the treatment. All that is, most of it you know the answers. The funda of eclampsia is, this is the worst case scenario. Moment you see a woman in the OPD, her blood pressure is, let's say, 140 by 90 at 24 weeks. More than 20 weeks, BP is high, 140 by 90, it is pre-eclampsia. So this preeclampsia, which was earlier known as PIH, which was then known as preeclamptic toxemia, the patient is preeclampsia now. You know what is coming to my mind? If there is proteinuria, and there is high blood pressure, convulsion na ho jaye. I hope she doesn't throw a convulsion. Convulsion varada pai virka, my Tamil friends. So she should not get convulsions. That is the only thing which is on my mind. Now she has had convulsions. The worst case scenario has happened. She's throwing a convulsion. What is going to happen next? She's going to die. Next thing, she's going to die. So the worst case scenario, all this hypertension, what I'm showing you, whether it's gestational hypertension, chronic hypertension, or delta hypertension, she should not have a convulsion, eclampsia. Moment she has convulsion, end of pregnancy. Yes, get that in your mind first. Eclampsia is the worst case scenario. After that, there's nothing left to continue the pregnancy. So today we are going to read, take out the baby, best treatment of eclampsia. So yes, after all of this, yes, gestational hypertension, eclampsia, and the delta which I told you, chronic, they can all end up and have liver and renal failure, intracerebral bleeding, abruption, HELLP syndrome. Yes, you know, hemolysis, elevated liver enzymes, and low platelets. Hey, hello, it happens only in hypertensive disorders. This HELLP syndrome, please read, it happens only in patients who have hypertension. Doesn't happen to you and me as men. Okay, HELLP syndrome. Then pulmonary edema, DIC, and finally death can happen. So eclampsia is the worst case scenario. So what do you do for a woman who has eclampsia? Yes, what do you do for a woman who has eclampsia? You terminate. Yes, you have to terminate the pregnancy. Very, very important. So yes, for eclampsia, therefore, this is therefore, all right. Therefore, for eclampsia, yes, the drug of choice is magnesium sulfate, and you next terminate the pregnancy. The funda in the first few slides we have to understand. Terminate the pregnancy. These are the MCQs. The best definitive management, INICET question, NEET question. What is the best definitive management of eclampsia? Magnesium sulfate is the drug which is going to prevent the convulsion. But what is the best definitive management? Please terminate the pregnancy. Now guys, after understanding drug of choice is magnesium sulfate and terminate the pregnancy, something else you have to do, guys. What else you have to do? Come. Are you answering here or am I there? Hi guys, good evening. And are you answering something? What else are you going to do? Come guys. Drug of choice, Maxwell, terminate pregnancy, correct. What else are you going to do when a woman has a convulsion? The convulsion is because of the high blood pressure. So you have to reduce the blood pressure. Look, if I had asked you, I'm saying what else you have to do. Some of you are not answering. If I had asked you, what is the drug of choice for hypertensive emergencies in pregnancy? All of you would have said labetalol. Drug of choice for hypertensive emergency in pregnancy is labetalol, correct. But guys, this is that emergency. Yes, this is that emergency, which is the only hypertensive emergency I deal with. Eclampsia, that's all. So what is the drug of choice of this condition for the hypertension? For this we are saying labetalol. All right guys, so plus labetalol. Don't forget this. So labetalol has to be given here. This is that moment where labetalol has to be given, guys. So yes, drug of choice magnesium sulfate, terminate the pregnancy, and labetalol. So get this understood at least. First you understand that, other things will follow in the chapter. Okay, now what else? We have understood the basic classification and what you have to do in eclampsia we understood here itself. Now what can happen? Just before eclampsia there is a stage where she is about to throw a convulsion, imminent eclampsia like we generally call it, or like we say the stage of worsening hypertension. She is about to throw a convulsion. When she is about to throw convulsion, imminent eclampsia, that is a very important MCQ for all you guys who are watching this INICET NEET. And if some MCI students are here, hi guys, you must understand imminent eclampsia is that stage which is worsening hypertension. She is about to throw a convulsion. You're taking rounds. You're my intern. You're taking rounds in the ward, and you come to me in my office. Sir, you have to come and see this patient, bed number 7. What happened? So her blood pressure is 170 by 120. So what else? So she's on 3 drugs. You started on labetalol and methyl-dopa and hydralazine. Still the BP is 170, 120. Come, let's go and see her. You see that woman is vomiting and she says, I have got headache, I have got blurring of vision, and I tap her knee jerks are exaggerated. And then I see she's also got epigastric pain. Why is she having epigastric pain? Guys, Epigastric pain in severe hypertension. Gas ho gaya kya? No man, epigastric pain is not because of the gas. It is because of a liver edema or a subcapsular hematoma in the liver. That's the reason why a woman is having epigastric pain. So those are the signs. Yes, epigastric pain is the liver. Liver is the reason. Liver hematoma or a liver edema, stretching of the Glissen's capsule. So nausea, vomiting, headache, blurring of vision, exaggerated knee jerks, epigastric pain, pulmonary edema, low platelets, rising liver enzymes, deranged renal function, blood pressure more than 140 diastolic, and proteinuria. Now proteinuria more than 2 grams in 24 hours. 2 grams in 24 hours. If more than 3.5 grams in 24 hours, we say it is nephrotic range. It is nephrotic range of proteinuria. All right. So all of this is telling me that she's about to throw a convulsion. What are you going to do, guys? Yes, convulsion, ho gaya, eclampsia. What do you do? Magnesium sulfate, 𝐼 and terminate the pregnancy. What do you do for an eclampsia? Yes, that is clear. What do you do for imminent eclampsia? Imminent eclampsia, that she's about to throw a convulsion. Imminent eclampsia, already mentioned in this slide for you guys. Yes, imminent eclampsia also is going to have this. So imminent eclampsia also the same treatment. So eclampsia, there's the treatment, and imminent eclampsia is also the same treatment, guys. Same treatment. That is, terminate the pregnancy along with giving magnesium sulfate and IV. I'm not telling you which is the method of termination of pregnancy. The termination of pregnancy can be by cesarean or a normal delivery, which is appropriate at that moment when she throws a convulsion or she's about to throw a convulsion. I've never said management of eclampsia is a cesarean section. No, 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 no. We are not saying that. Terminate the pregnancy is the management. How you do it is decided by the obstetrician at that moment. So let's move on and see. Yes, what is the basic etiology of hypertension pregnancy? So if we see hypertension, very, very simple, guys. There is a uterine artery which is giving the blood supply. All right, uterine artery giving the blood supply, and there is a placenta. There are the radial arteries, the basilar arteries. Radial are these basilar arteries, and this is giving blood supply into the, yes, where is this? Yes, they're giving some blood. Yeah, they're giving some blood in this placenta. All these arteries are giving some blood in the placenta. Now the baby which is attached here, he's going to send his, guys, concentrate, do not look left, do not look right. This is the most important part of the chapter. The earlier screens were the introduction. Now concentrate, don't look left and right, and don't have to answer anything right now. I'm not looking at the comments which you're giving. We are worried about you understanding this, so do not get distracted whatever happens. So the baby is sending his villi and the mother is sending her spiral arteries. The spiral arteries is making this red pool of blood in the placenta, and the baby is sending his villi into this. So yes, how does the mother give nourishment to a baby in pregnancy? The blood comes into the placenta and the villi go into the placenta like this. Look at this. This is the syncytium. See my fingers, syncytium, जाल हिंदी में बोलेंगे ना. There's a syncytium, एक जाल है. So syncytiotrophoblasts and the cytotrophoblasts, that's what makes the villi, isn't it? So this villi enter the blood of the mother, but the baby never takes the blood of the mother. Only in the movies it is correct, okay, that mother says, I've given you my blood for 9 months. तुझको मैंने अपना खून पिलाया है. No, no, no. We never take a mother's blood. I'm A positive, my mother was B positive, all right? So we have never taken our mother's blood, okay? We have never drunk the blood, okay? That's crazy to even say. So our villi are entering the mother's blood circulation, and when the villi of the baby enters the blood circulation, the villi will take what? Oxygen, minerals, electrolytes, carbohydrates, proteins, fats, everything is taken by the villi, but never the RBCs. So villi, these villi are like straws. They go into the blood and like that, they keep sucking in the nourishment, but not the RBCs, all right, guys? So this, all of this is based on a good blood supply in the placenta. So these spiral arteries, yes, look at these spiral arteries. These are the key of our discussion today. So after 20 weeks, what happens? What am I going to teach you about the hypertension in pregnancy? especially the gestational hypertension, chronic hypertension, medicine guys, okay? They are much qualified medicine guys who are going to teach you about hypertension overall. Chronic hypertension, pregnancy, their headache. My headache, drug of choice is Levodopa. We are talking about gestational hypertension. If there is gestational hypertension in pregnancy, that gestational hypertension has to be because of a poor placentation. Placenta theek nahi bana. If you can just remember this much, my job is already half done. If anywhere in your life, suppose you become a dermatologist and you've got nothing to do with pregnant patients, and sometimes they'll ask you, what is the cause of hypertension in pregnancy, the gestational hypertension? Bad placentation. If you remember that, you attended my class. So yes, bad placenta. What is the meaning of that? The placenta is formed, and this placenta is giving the blood supply to the spiral arteries. So these spiral arteries should have normal pregnancy will have vasodilation in this spiral arteries. So let's understand this picture by a much more better advanced picture. This is inspired by Williams Obstetrics, the perfect book to read for obstetrics. So if you look at this picture, you'll understand what's happening here. That the mother is having this spiral arteries. Dekho, these are the spiral arteries here, okay? These are giving the blood supply here. Maybe I should have made this black thing. This is basically red, okay? So all this blood which is going, this is the placenta, okay? So spiral arteries give the blood, and the villi dip into this blood, and they take the nourishment. So villi, see, anchoring villi, then the syncytotrophoblast. See, these are the syncytotrophoblast, these fronds, cytotrophoblast, these cells are the cytotrophoblast. They will invade the spiral arteries and they will replace this muscle layer, guys. Spiral arteries lose the muscle layers. So please understand here, from the villi, they are trophoblasts. So we call them extravillous trophoblasts. See these cells, and they will come to the muscle layer of the spiral arteries and replace the muscle layer. Endovascular extravillous trophoblasts, INICET guys. This is what comes in your exam. Do not get distracted and do not get dissociated with the topic. I forbid you. Most important part, INICET favorite question. The cytotrophoblast from the villi comes into the interstitium and then comes also into the smooth muscle layer of the spiral arteries, and the smooth muscle layer is replaced. Look at this last picture. There is no smooth muscle left. There are only cells. Look at the diameter of the spiral arteries. Look at the diameter of the spiral arteries at the third trimester. It becomes vasodilated. So good vasodilated blood vessel obviously will get good supply into the placenta. So endovascular, once more, cytotrophoblasts in the villi. Outside the villi there are cytotrophoblasts. They go into the blood vessel. So extravillous, outside the villus, but in the blood vessel, endovascular. Endovascular extravillous cytotrophoblast. This will cause the replacement of the smooth muscle. Then there will be some interstitial. See this interstitial cytotrophoblast. So again, they are outside the villus, extravillous, but in the interstitium. So which is the one which is replacing, which cytotrophoblast is replacing the smooth muscle in the spiral arteries? That's the question which came in your INICET 2 years back. I know that because INICET is JIPMER, AIMS and PGI, and my college JIPMER, I know what questions they are going to ask, okay? My MBBS and MD in JIPMER, they've taught me that one or two questions they'll give so tough, others will be very easy. So when the tough questions come, they come like this. So the extravillous cytotrophoblast will come and replace the smooth muscles, and that is going to give a vasodilated blood vessel and a better perfusion. Now, if this is inadequate, if this invasion, like we call it, this invasion of the cytotrophoblast in the smooth muscle, if it is inadequate, then there is persistence of this type of blood vessels. You have to understand, if this type of blood vessels are persisting, how much will be the nutrition? How much will be the blood supply? Yes, will it be more or less? If this vessel, the vasospastic vessel, is persisting, obviously the blood flow going into the blood amount going into the placenta bed will be much lesser. So that's the reason that the baby is getting less nourishment. So the mother gets a auto-regulatory information. baby is getting stressed, he's making catecholamines, and those catecholamines go to the mother, and the mother starts increasing her contractility of the heart and increase the blood pressure to overcome this vasospasm. Making some sense? It's like me sipping lemonade. I'm sipping lemonade and I have a straw, and when I'm sipping the lemonade, a seed comes into my straw. I'm not able to sip the lemonade again. So what do? I go out and I push the lemon seed out. So that kind of mechanism, that this blood vessel is having lesser flow, so mothers increase their blood pressure to overcome this vasospasm, and that's why the blood pressure increases. So yes, normal pregnancy there is vasodilation, and what happens if inadequate, like I showed in the previous screen, there will be vasospasm. There will be vasospasm. So this is the main pathology. Main pathology is vasospasm. So remember, etiology is poor placentation. What is poor placentation? Vasospasm. Now this is predisposed by two factors. Yes, you can remember that. First exposure. You can remember these things. First exposure to villi from the baby, or exposure to excess villi. Two things. Exposure to villi for the first time, primigravidas. INICET guys, get ready for this kind of questions, man. Exposure to excess villi. Excess villi matlab too much of villi. Oh god, that was not good. Okay, too much villi, like in molar pregnancy and in twins. So yes, there is excess amount of villi exposure when there are twins, when there are molar pregnancies, and also when there are the first exposures like the primigravidas. So yes, that's why the first exposure to villi and poor placentation, vasospasm causing less perfusion, so mother increase the blood pressure. So the mother increase the blood pressure to overcome the vasospasm. To overcome the vasospasm. Now the blood pressure is not high just in the uterine arteries or in the placental base, isn't it? The blood pressure is high everywhere. The blood pressure, same high blood pressure goes to the kidney, zigging. It goes and breaks the glomeruli, proteinuria. Same high blood pressure goes to the eye, papilla edema, retinal hemorrhage, detachment. Same high blood pressure goes to the liver, SNR damage, subcapsular hematoma. High blood pressure to the brain releases glutamate, causes convulsions. So that high blood pressure is not just to the placenta, and that's why the woman has the proper syndrome of preeclampsia. So once you understand that, other things also contribute, guys. Let me see what you guys are saying. Other things which contribute. Okay, all right, these are looking like general comments. We'll come to your question later. So we are talking about the etiopathogenesis, and we've discussed about the major problem being the placenta itself. And when the patient has vasospasm, the mother increases the blood pressure to overcome the vasospasm. Now, why is there vasospasm? I discussed. Now, what is contributing to the vasospasm is the next set of questions. Understand, there are three other things which contribute. So, contributory to the pH. One is the immune system. The T helper 1 cell function increases. Normal pregnancy has 2 helper 2 bias. Again, INICET question. I'm writing IN to say INICET question. Again, T helper 2 is the normal bias in pregnancy. T helper 2 function increases. They are causing vasodilation. They are good immune cells. But T helper 1 cell function increases in some pregnancies, and they increase the inflammatory cellular messengers, cytokines. Cellular messengers, cytokines are the pro-inflammatory cytokines will be increased, like the tumor necrosis factor alpha, or the interleukins. Okay, interferon, I'm sorry, gamma interferon, I beg your pardon again. Okay, I'll cut this. gamma interferon. Okay, not interleukins, I was saying gamma interferon. So gamma interferon, tumor necrosis alpha, these will contribute. They'll be coming from the T helper 1 cell function, and they are going to cause more vasospasm. So the helper cell function also is contributory. Now, imbalance between vasodilators and vasoconstrictors. This is what you know right from your MBBS days, right? Vasodilators reduce, vasoconstrictors increase. So there is reduction in prostacyclin. This is what is coming, PGI2. This is again INICET question. And reduction in nitric oxide. But there is increase in thromboxane A2, and there is increase in angiotensin. So vasoconstrictors have increased and vasodilators have reduced. So they will ask you the ratio. This is what came in the INICET exam. What happens with the prostacyclin and thromboxane ratio? Prostacyclin and thromboxane A2 ratio. This was the MCQ. Obviously, if this is reducing, then the ratio also reduces. But if you knew this detail, then only the ratios will make sense, isn't it? So what else? Now this is what is very important. Imbalance between, guys, don't lose interest. These are all questions. They are coming. They're tough chapters, and this is what was selected for you to be reading, because there are 2 chapters in medical disorders. GDM, hypertension. Without that, you cannot leave the rooms when you're writing INICET exam. Okay, so that's why it was a chosen topic for you guys. It's a decision of the academic committee. Please read this nicely. Yes, you're getting tired, fatigue. Last bit, last tough part. Okay, hold it. Don't let it slip. Pakad ke rakho. Imbalance between angiogenic versus anti-angiogenic factors. We can understand this. So we are reading vasospasm. Why vasospasm? Plaster is not formed properly. What is contributing? Immune system abnormalities, imbalance between vasodilators and vasoconstrictors. Now, imbalance between angiogenic and anti-angiogenic factors. What are angiogenic factors? We want blood vessels to form in a placenta, isn't it? So, transforming growth factor. Then vascular endothelial growth factor. I'm not writing the full forms, guys. I'm sure you know them. But these get bound. They are bound with, they get bound by rather soluble endoglin. Hold it, guys. Hold it. Don't leave it. Or this vascular endothelial growth factor bound by soluble FMS like tyrosine kinase 1. Soluble FMS like tyrosine kinase 1. Yes, you're splitting your heads already, I know that. So, transforming growth factor and vascular endothelial growth factors are angiogenic. They make blood vessels. We want them in the placenta. Like in the eye, you don't want VEGF. Opthal wale padhate, right? Vascular endothelial growth factor in the eye will cause neovascularization. You have to give anti-VEGF. Yes, all that you know well. I want angiogenesis here. I want a good placenta for the babies, right? So, angiogenic factors, transforming growth factor, vascular endothelial growth factors, these are all required, but they get bound by soluble endoglin, SENG, and they get bound, the VEGF gets bound by soluble FMS like tyrosine kinase 1. So, SFLT1 and SENG. Guys, these are commercially available tests. You girls can go and get this test done. Lal's lab, or, oh, I'm not telling you names here. Any Lal's lab or any Ranbaxy lab, Thyroket, just go and get this test done. And these are already available commercially to understand whether you're going to get preeclampsia in your pregnancy later. Yes, big statement, guys. So understand, these are available tests. You can get these special tests done. So that's why they're coming in INICET. So all of this will contribute to vasospasm. Don't forget the punchline so far, vasospasm. Now, the easier part, this part you know guys very well. This is there in all your books. The other factors which predispose, primigrata will have more, molar pregnancy in twins will have more. I told you about the villi story already. Then grand multigravidas, more than or equal to 5 pregnancies. Okay, you can say more than 4, that is 5, 6, 7, or more than or equal to 5, which is again 5, 6, 7. So more than or equal to 5 pregnancies. Okay, pre-existing disease like renal disease and diabetes mellitus, genetic disease like methyl tetrahydrofolate reductase deficiency and factor 5 laden deficiency. All right, deficiency is the word here. I think it's come here by adjustment. And antiphospholipid antibody syndrome and SLE. These are all contributory factors. Pathology of organs, liver will have a acinar damage. The acinar damage will cause the patient to have subcapsular hematoma. So this is the easy part of the chapter now. Kidney will have glomerular endotheliosis. What is glomerular endotheliosis? Look here, the normal glomeruli of a woman who is pregnant. The endothelium is having these fenestrations, these holes. Can you see these blue things which I am making here? The endothelium has this fenestration which are going to perfuse the kidney. Now, when there is endothelial swelling and endothelial damage causes the swelling because of the high blood pressure, correct? The high blood pressure is damaging the endothelium of the blood vessels, and when they become swollen, see, when they become swollen like this, see guys, this becomes swollen. When they become swollen, these fenestrations are now getting closed. So, big, small. Fenestrations are closed, perfusion is less. See this, look at this pink area here and look at this pink area here, endothelial swelling. That's why the perfusion is less, kidney gets damaged, proteinuria, and the problem of renal injury in hypertension. So this, if you do not remember what I explained here, remember glomerular endotheliosis. Question to aayega boss, questions will come. Then RBCs will have hemolysis. Yes, that is due to endothelial cell activation causing microangiopathic hemolysis. So what is the evidence of hemolysis? All of you know, increase in lactic dehydrogenase and decrease in haptoglobin. Yes, you know, when there is hemolysis, the hemoglobin will be free. RBC has got lyse, but the hemoglobin is free. That free hemoglobin will be circulating all over the body, and that free hemoglobin is injurious to the vital organs. So that's why the hemoglobin has to be bound by haptoglobin. Now haptoglobin is bound by binding the hemoglobin, it's getting utilized, haptoglobin. So the haptoglobin levels will reduce. Of course, there will be increase in the schistocytes, broken RBCs, echinocytes. Of course, increase in bilirubin also is there. All that you guys know better than me. So yes, increase LDH and decrease in haptoglobin. That's what you have to remember. And then what happens to the brain? Intracellular hemorrhages, visual scotomas, and convulsions due to increase in glutamic acid. So that's what causes the irritation in the brain. MCQ again, guys. So treatment of hypertension pregnancy. I'm not going to go into the details of the pharmacology here. There are much qualified people telling you that. But yes, drug of choice, labetalol. Hey, hello, I'm talking about the OPD management right now. Do not get confused. OPD management mein we are talking tablets of labetalol, and that is 100 to 200 milligrams 3 times a day, and we can give up to 2400 milligrams in 24 hours. Tablet, guys, tablet. How much you can give? Because IV labetalol we'll discuss with eclampsia. Okay, then she cannot, because she's convulsing, she cannot take oral drugs. So IV labetalol we'll discuss later. But OPD mein labetalol, all of you know it is alpha plus beta blocker. It is the drug of choice. The previous drug of choice was methyl dopa. Now why I'm writing this previous drug of choice? Because in one exam they asked what is the drug of choice, and labetalol was not in the choice. That was one MCI exam in 2022 December. We keep telling all INICET students and NEET PG entrance students when we are taking the classes that please remember drug of choice is labetalol. But some old question bank, I think they did not give labetalol as a choice. So just in case an error happens like that, I'm sure you know that labetalol is going to come. And methyl dopa was the previously selected drug. You know, it's a pro drug. It makes alpha methyl norepinephrine in the body. And side effect iska yaad rakho. The dose is 250 to 500. My favorite drug actually, QID. It takes 48 hours to show the effect. Now, this methyl dopa, the side effect, apart from all of that, indirect cum test may come positive. You think that she's got a hemolytic anemia, and she will also have drowsiness, and she will have some depression with these drugs. So I'm not going to much detail. I'll just tell you there is hydralazine. Please read about hydralazine, 25 to 50 milligrams per day. We can give it twice a day also. Mostly OD dose is enough. Then we can give nifedipine. Nifedipine is a very good drug. No more sublingual nifedipine. Sudden hypotension can happen. And then we have prazosin, alpha blocker, 2.5 milligrams to 5 milligrams a day. So just OPD management, drug of choice labetalol. Remember, it is alpha plus beta blockers, so avoid the beta blocker action. Please avoid in bronchial asthma. Yes, so there is a controversy on that, but we are not going to that today. Okay, so let's see contraindicated drug. Now, this is like, I don't know why they ask this so much, especially in INICET and MCI. INICET, MCI, NEET वालों को छोड़ देते हैं ये वाला question, because this question is like, if you are a doctor, you have to know this, that contraindicated ACE inhibitors. This you cannot forget. ACE inhibitors, captopril, enalapril, whatever. Remember, rimapril, hypocalvaria, renal agenesis, and intrauterine growth restriction. And of course, furosemide is contraindicated, which is going to cause the IUGR again. IUGR, huh? Other things, okay, I'll लिख देता हूँ यार, इसमें confuse नहीं होना बाद में. IUGR, and then beta blockers. Yes, here I can follow this. It causes IUGR again. So beta blockers, furosemide, and ACE inhibitors, because furosemide will increase the fluid out of the mother, and mother is having vasospasm, guys. She's not having volume overload. Remember this one thing, very important. Hypertension pregnancy is not volume overload. Did I even mention volume overload all this while when we are having this discussion? No. Volume overload happens to you and me if we get hypertension. She's not volume overload, guys. Don't do this mistake. That's why hypertension pregnancy is managed by gynecologists. Physicians are involved only if we cannot manage it. Otherwise, mostly we are able to manage because there's a different pathology. It's a problem of vasospasm, less fluid in the placenta, less fluid perfusion to the baby, and the mother's circulating volume is also less. So if you give furosemide, mother will drain out more fluid out of her body, and the circulating level of the mother's, yes, the mother's circulating volume will be less. So the perfusion to the baby is as it is less, and if you take out fluid by furosemide, there will be still further reduction of baby's perfusion. Remember, furosemide is not given because it promotes IUGR. So you and me, if we have hypertension, we get furosemide, isn't it? But the mothers who are pregnant, we never give them furosemide. Hello, we also don't give salt restricted diet for the same reason. Yes, we don't give salt restricted diet in hypertension pregnancy, especially gestational hypertension, because the pathology is different, etiology is different. We give normal salt diet. Of course, we don't give excess salt diet, that is correct, but we give a normal diet. We don't give a salt restricted diet. These are very important facts, okay? Tough chapter picked up today, but never mind. We are good for it, isn't it? So fetal surveillance. So apart from doing the blood pressure management by the drugs, you have to do fetal surveillance. Some other time we'll read this in some other place. We'll do another class on this fetal surveillance. Extremely important chapter. What is the drug of choice for hypertension pregnancy? Labetalol. What is the drug of choice for diabetes in pregnancy? Insulin. That doesn't make you an obstetrician. You know this drug of choice. Your pharmacology is fine, but you will become an obstetrician only if you know how to continue this pregnancy till term and deliver it vaginally. So surveillance makes me an obstetrician. I know how to manage the blood pressure, but I know how to take care of the baby's movements, baby's non-stress test, baby's biophysical profile, the amniotic fluid index of the uterus. All of that I'll see, and then I'll buy 1 week. Next week I'll see the Doppler of the the Doppler flow of the uterine arteries. If that is fine, I buy another week. Okay, how I continue the pregnancy with hypertension pregnancy, reach till term, and give a normal vaginal delivery. That is obstetrics. All right, guys. Cesarean section is not the answer to obstetrics. Okay, that's not the result. I mean, that's not the one-stop treatment of all problems in obstetrics. Please remember, surveillance is obstetrics. So we'll discuss this. There is NST, biophysical profile, Doppler, Also the DFMC, daily fetal movement count, more than 10 per day. It is done by the mother, isn't it? The mother does this daily fetal movement count. She tells baby has moved more than 10 times in this 24 hours. So surveillance, bus itna today. We'll do this in some other time. So we do the surveillance. Now, what is the treatment of an eclampsia? Now, the hot shot topic has started now. Apart from the etiopathogenesis, this is the hot shot topic. What is the drug of choice? If a woman has convulsion, now convulsion, drug of choice is magnesium sulfate. You cannot stop this one convulsion. You know, a lot of you get confused. She's convulsing. If you give a Maxilf IV, it's not going to stop this one. The brain has already discharged all the impulses. So this convulsion won't stop. The next convulsion has to be prevented. So magnesium sulfate is drug of choice, and the regime of choice is the Pritchard regime. Pritchard regime. It is an IV plus IM regime. Pritchard regime only. Oi, I'm getting a little worse on severe on you guys. Only. Don't read all the other regimes, which when I was in my MBBS 1993-94, when we were final year MBBS in writing exam, we were told very clearly in JIPMA, forget all the other regimes. That time we used to have, when I was a final year student, we used to have the lytic cocktail and the Leans regime and the Menon's regime. Outdated then, 31 years back. So please guys, remember, you have to give only the Pritchard regime, and if you are reading the other regimes, you are wasting your time, totally wasting your time. So Pritchard regime only. Dose is 4 grams. Please do not say milligrams. 4 grams IV plus 10 grams IM. IM is split because, yes, you know, 10 grams, 1 gram is in 2 ml. If you worked in your labor rooms, all you interns will understand 1 gram is in 2 ml. So if you give 10 grams, it's 20 ml. So you have to split in the 2 buttocks, isn't it? 5 grams in 1 buttock and 5 grams in 1 buttock, which is actually 10 ml of an injection, 10 ml each. So remember, when we get the TT injection of 0.5, our hands are hurting so much that we are not walking. You know, this hand moves and this hand you don't move at all. You're walking like this. So that's what is the problem. If you give 10 ml into the bum, it's going to hurt us so much. So that's why you must give these injections, guys. Don't bunk internship, those who are doing internship right now. Give these injections to understand how difficult it is. So we give plus 1 ml of lignocaine. This is not part of the regime, huh? This is friendly advice by your senior here. Okay, give some lignocaine. It hurts the woman a lot. So yes, 4 grams and 10 grams is the dose. How do you give it? Some other time. 14 grams is the loading dose. You can give plus 2 grams IV if the convulsion doesn't stop. But the best definitive management is the delivery. Terminate the pregnancy, whatever duration of gestation. Yes, there's nothing called that. Why don't we wait for 2 months, 2 weeks? Why don't we get 2 days? Get the lung maturity? Nothing. Start the delivery process. Okay, start the delivery process. How you do it? If she's in labor, she's let's say 37, 38 weeks, she's in labor, do a normal delivery, augment the labor. If she's 35, 36 weeks, we do cesarean so many times, terminate the pregnancy. It is the best definitive management because the blood pressure is normal. Blood pressure normal in 90% patients in 1 week. That's the reason why this is the best management, because the BP is normal in 1 week in 90% of patients. Right. Now, continue the magnesium sulfate. Remember, if a woman convulses, let's say at 10 p.m. tonight, you do the delivery. After the delivery, don't you think she can throw convulsion again, because the BP is not going to fall immediately. So after the delivery at 10 p.m., you must continue the Maxilf for 24 hours. So you give Maxilf at 2 a.m., 6 a.m., 10 a.m. tomorrow morning, 2 p.m. tomorrow afternoon, then 6 p.m. and 10 p.m. tomorrow night. For 24 hours, you have to give the Maxilf. And when you're going to give the final injection, the tired intern goes to give the final injection 10 p.m. tomorrow night, and that time she throws a convulsion again. So 24 hours more, whichever is later. Earlier nahi, later. Intern, काम करना है, ठीक है? So continue magnesium sulfate for 24 hours. 24 hours after delivery or last convulsion. Okay, whichever is later, not earlier. So how do you monitor this? I mean, solid MCI, INICET, NEET, सारे लिख दिए भाई. Solid. Do not leave your rooms without reading this, monitoring the magnesium sulfate, because this is what is telling us that you worked in your internship. Okay, so knee jerks should be present. Knee jerk should be present. You know, it is 0, 1, 2, 3, 4, the grades. At least minimal knee jerk should be present. Respiratory rate should be more than 14 times in a minute. Why these two? Because magnesium sulfate, MgSO4, is a cerebral suppressant, a central suppressant. So that suppression which is going to stop the convulsion may become so much that it may reduce the knee jerks and the respiratory drive, and the mother may go into a respiratory arrest. So please, these should be present. Urine output should be more than 100 ml in the last 4 hours. So yes, magnesium sulfate has to be continued for 24 hours after delivery, and that's why we give how much? We give something like 5 grams 4 hourly. 5 grams 4 hourly, HRLY, hourly. Okay, I think I'll get better with this pen, and maybe next time I'll write better, I promise you guys. So 5 grams 4 hourly. So when we are using it 5 grams 4 hourly, we have to monitor 4 hourly, monitor this 4 hourly. So knee jerk should be present before the next injection, respirate should be more than 14 per minute, and urine output should be more than 100 ml in the last 4 hours, because MgSO4 has renal excretion, so that's why. Okay, that's why if the magnesium sulfate is not cleared from the body, he's going to have side effects. That's why. So therapeutic levels of magnesium sulfate are 4 to 7 milliequivalents per liter. Okay, chalo. So this is about the continuing regime. So while you're continuing the magnesium sulfate regime, there can be side effects. Quickly, let's finish this topic off now. First sign of magnesium sulfate toxicity is knee jerk suppression. Knee jerk suppression, which happens at 8 to 10 milliequivalents. Okay, 8 to 10 milliequivalents I'm writing, which is per liter. So normal is 4 to 7 MCQ, and this has come in your NEET exam. Knee jerk suppression, 8 to 10 milliequivalents, first sign of toxicity. More than 15 milliequivalents, there will be a respiratory arrest, and more than 25, there will be a cardiac arrest. So treatment of magnesium sulfate toxicity is calcium gluconate, and that is given all of you. You have to mug up this dose, and I'm sure you know 1 gram IV in 10 ml given over 10 minutes. Okay, given over 10 minutes. So IV 10 ml over 10 minutes. Please remember that. For hypertension control, now she's convulsing, guys. In this scenario, I mean to say I'm not talking about OPD management now. So you give IV labetalol, and this IV labetalol is given 20 milligrams. Now if she does not respond, then after another 10-15 minutes, we can give another 20 milligrams. Doesn't respond, I can give 40 milligrams. Doesn't respond, 80 milligrams bhi de denge IV. Okay, up to 220 milligrams in 24 hours. Guys, this is the dose of the IV regime. Please do not get confused. We are talking about IV 24 hours is 220. Tablet in 24 hours 2400. Okay, not to get confused, guys. You're going to be doctors, right? These are all basics. So yes, we can go ahead and give IV labetalol, and up to 220 milligrams we can give. So timing of delivery, mild hypertension, controlled on drugs, we can go up to 39 to 40 weeks. Somebody got angry with me when I was writing my, after my MD, I gave my DNB theory, practical immediately. And in my, the DNB practical exam, somebody got angry with me when I told this, because this is exactly how we manage in JIPMA. A woman who is having a good control of the blood pressure, mild hypertension, you don't have to do an early delivery. Mild hypertension, blood pressure 140/90, around maybe 100 diastolic, and you control well, and the BP is now, blood pressure now normal, you don't have to get worried. Deliver at term 39, 40 weeks bhi ja sakte ho. But yes, uncontrolled hypertension, high requirement of drugs, 37 weeks. And prevention of hypertension pregnancy, calcium supplementation, and then we can give patients something like low dose aspirin. Low dose aspirin is, all of you know, 75 milligrams per day to 150 milligrams per day. Or we can also give omega 3, yes, omega 3 fatty acids, fish oil, which is there in fish oil. No wonder Japanese have the least PIH, because they take a lot of fish. Right, guys? Okay, I know marathon ho gaya na, from one shot se marathon ho gaya, but doesn't matter, guys. We are here to take your questions. And what are you guys asking me? Okay, team, PW team, can you just scroll down this for me? Anybody? FMG के बाद क्या class ले सकते हैं ये? Yes. Okay, I can take it again. आपको, okay, how do I go up and down? Anybody can help me on this? Any questions, guys? You can speak up if you can't hear me. Yes? I think let's talk about the questions. Yes, anybody who is... Okay, so if you're not having any doubts to ask me, then I think we are good enough. And can I just say that we can conclude this session? Guys, any questions? How do I'm just getting used to the super duper technology which is here in my studio. Is imminent and impending the same? Yes, correct. Synergism, your question is correct. Imminent is about to throw a convulsion. Impending is about to throw a convulsion. That is correct. Yeah. No, no, it is part of preeclampsia. HELP syndrome doesn't happen to any woman or a man just like that. It is associated with only with eclampsia. HELP-like syndrome, a lot of people say it is a HELP-like syndrome to associate this kind of presentation in other conditions. Okay, or medicine people will teach you that HELP-like syndrome is what is used. HELP is totally obstetrics and gynae associated with hypertension. Good question. Now, how do I scroll this? I don't know. Okay, I tried, but I don't think I know how to do this. Okay. Yeah, I think I got it here. All right, not bad. You're asking me some questions. Good evening, glitches, gestation, laboratory, IV, imminent eclampsia. Okay, fine. I guess that's it. Thanks, Tushnik. मैं गलत पढ़ा रहा हूँ. शिवम प्रसाद, yes, tell me. हम आपको बर्बाद कर देंगे. Thank you so much. What happened, Shivam? क्या गलती लग रही? Shivam. All right, guys. So I guess I'm going to take away this class from now, and whatever you understood, I hope it is good for you, and we shall meet again for any session very soon. And thank you so much for your time, and God bless you. Best wishes for exam. Yes, you're here?
So one last question.
Yeah.
In Pathophysiology
कौन सा एनेस्थीसिया? All right, because any emergency we go for a GA, and if there is a patient who is planned for a emergency which is life threatening for the baby, we go for a GA, immediate induction. But if there is that is a fetal distress, we'll go for a GA. But there are many times when the distress is fleeting, so many of our anesthetists are able to give a spinal anesthesia very fast. तो हम लोग स्पाइनल भी दे सकते हैं, but distress अगर है तो GA है. Now hypertensive disorders in pregnancy, go ahead and give epidural, no problem. Epidural भी दे सकते हैं because we are not in emergency, it's just hypertension is there. So when there's an emergency, we are happy with spinal and GA. GA more, next spinal. But when we have slightly more time, we can go ahead with epidural also. तो आपको जो न्यूरोएक्सिल एनेस्थीसिया पढ़ाते हैं, so that is what is the epidural and the spinal, and any emergency I'll go with the GA. But I can give spinal even for eclampsia. It's not that in eclampsia you should not give a GA. You should only give a GA. It's not like that. In eclampsia you can give a epidural also and a spinal also. Yeah. Yes, we are going to come up with our videos also. As of now, we are recording the videos for your app. I just joined recently the PW team, and we are making videos, so you will get your rapid revision also, definitely. But maybe not in time, let's say, for this FMG exam. I hope I can do it, but the idea is to give you the main lectures first. Yes, definitely it is coming up. Right, team, thank you so much. And if there are no more questions, good evening, and hope you keep reading very well. All the best for exams. Thank you. Hello. Hello.